let's see there. Okay, Miss Wash is on here. I was looking for her. Um, and
And can you hear me now?
I can.
Okay, great. Um, Welcome everyone. I'm still clearing the waiting room. You do have everyone on but Joe Petrie.
He is in the drive back right now, so he is going to be getting on by phone at
Okay,
some point. So,
okay. I hope I can recognize the phone so I can let him in. I also want to introduce to you today Danny Davis, who is now the new Mac back and tech liaison, and I am helping her acclimate into her position. And Danny is on it. You want to unmute for a minute, Danny, to say hi to everybody?
Hello, everyone. It's nice to meet you all, and I surely look forward to working with you.
nice to meet you.
All right. I still don't see Joe Petrie here yet.
Is there's so many coming up. You got is Dr. Cruz? Yeah.
Yes, we have Justin, Caitlin, yourself, and Dr. Cruz.
Okay.
Everybody else is on.
All
I
right.
think I see them all. All righty. It is 2 o'clock, and I guess we can proceed.
All right. So welcome everyone to the dental TAC meeting for 213. We do have officially a quorum established. Can we have a roll call? Dr. Robert Millay, myself here. Dr. J. Cruz.
Second here.
Oh, there you are.
Uh,
Uh,
Trying to get my video going, but I can't get it.
okay. Dr. Klasa.
Here.
I see you up there. Yeah. And Dr. Patel.
Here.
So we do have a quorum. Next motion, this will be a motion to approve minutes from 11/14/25 of the dental TAC meeting. Do we have a motion to accept those minutes as noted?
Move to do that.
In a second.
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 Move those minutes be accepted. We'll need a vote of members, and sadly, since Dr. Cruz is having issues on his camera right now, can we do a vote without his video? Will
Yeah,
that
I'll
work?
motion and then it looked like Joe's second, and so we'll switch that.
All right, sounds good. Is there any business that needs to be
It should
addressed?
work now.
Oh, there we go. Perfect, Dr.
There
Cruz.
he is. Okay.
Is there anything needing from representatives to speak or address the TAC? Anything right now before we get into new and old business? Hearing none, we'll move to old business. There were some things from the 11/14/25 meeting that it was going to be followed up on. I have not heard any follow up on some of those points. I was wanting to bring those up to see what the status was on a few of those points. Um, the first one was the children having an option to switch from Aetna to another MCO if there wasn't a provider in the area. And I was wondering what the status was on that. I know the question was, can is that possible? And there was questions with the eligibility. I think it was noted. I think it was Mr. Derringer maybe that noted we may need to send somebody to eligibility to get issues to get an answer back to see if that is possible. And I did not know if that was possible or not.
So Justin is online. I don't know if he can unmute. There he is. I see him.
Hi, yeah, I don't think that do we have anybody from eligibility on, Barb? I don't, it wasn't on the agenda, and so
Mm-mm.
because it wasn't on the agenda, I don't think we're able to have anybody on. I think they did, or they were working on a response. I'm not sure if they never sent it back to me. Maybe they were waiting for this tack. But again, when the agenda came out, it wasn't listed on there, so we don't have anybody from eligibility, I don't think, on this call. So, Barb, can you get with eligibility or
Yes,
Danny after the call and have them submit that to the TAC members? Because I know they received it and we're working on a answer for them.
I knew after the last meeting, it was hoped that we'd have something back in about a week, and I had never heard anything. So I wanted to touch base again to see what we are. When should we expect that response from them?
I'd say by Friday of next week you'll have something.
Friday of next week?
It's late in the day Friday, so again, that's not my division, so I'm kind of speaking for them, but I know they have it and they looked at it and probably could have got your answer today, but again, it wasn't on the agenda.
Okay, so I will need to follow up with you directly or who, Miss Wash?
Yeah, follow up with Miss Wash and she'll kind of be the liaison, the kind of the go-between. And then Barb, if you'll CC Danny on that.
I will.
Okay, so just kind of keep her in the loop and
Hmm.
yeah. And let eligibility know that we need something by Friday, the 20th.
By Friday.
Yeah.
Okay.
And I know, kind of in the same lines, Miss Parker had, and I don't know if she's on today, had mentioned that there was something in the Aetna. I could not find anything in the Aetna contract regarding that when I reviewed it. I know on page 109 of the Aetna's contract, it specifically mentioned the Sky program, and that patients could move from another MCO to the Sky program, but there was nothing mentioned in page 109 or anything I could read after that that dealt directly with something going backwards. So I know she was looking at that a little bit, and I don't know if she's on here to be able to address that.
We had a representative from Aetna. I'm not sure that they're,
Yeah, I don't see Miss Parker on today.
no, I don't see Miss Parker on there.
So that'd be part of probably the follow up with the other one next week. I'll reach out to you if we don't hear anything by then. Hopefully they'll have that answer for us next week. What is the another follow up that was supposed to be reached out to us? What is the status of the dental director compliance? I'm assuming all contracts are the same. I know that at least I was reviewing Aetna's since they were out of an actual dental director right now, with the subcontractor with Skygen. And on page 157 of the one I reviewed, section 1F says a dental director licensed to practice in Kentucky must be on the executive team. A dental director shall be actively involved in all oral health programs of contractor and devote sufficient time to ensuring timely oral health decisions. The dental director should be available for after hours consultation if needed. Since that's specifically in the contract, what is the status of that dental director for the state of Kentucky from Skygen and Aetna?
Well, this is Larry Paul from Skygen. So we have had Dr. Tran serving as our interim dental director, who has served all those functions that you had mentioned. But I'm also happy to, and we've been working closely with the person who will be our full-time dental director going forward. And I'm happy to announce that we've worked through some of the challenges with bringing that person on board, and he is coming on board. It's Dr. Andy Elliott, who brings a great deal of experience and a great deal of knowledge of the Kentucky market. So we are just now going through the onboarding process with him. There have been some challenges with getting him on board sooner, but he was really the one we were focused on because I think he'll bring a great deal of value long term. So that is in the works.
What is the status of that onboarding looking like at this point? Do you have an estimated time frame of when that would be completed?
I really don't, but I think it should be within the next couple of weeks. I would say there are some steps that have to be undergone, but it shouldn't be too much longer at this point.
Is there BJ? Do we know who the DentaQuest
I have not
director
heard
is?
of the DentaQuest. I've not been a DentaQuest provider for a while, so I don't know on the DentaQuest status.
It'd be good maybe if Justin, I don't know if we could maybe get a list of who these people are tentatively are or going to be. So when people are asking me to what I think about them, I at least can give them a name to communicate with as far as a dental director.
Because that would be, correct me if I'm wrong, I believe that would only be Humana at this point in time that is using DentaQuest as a subcontractor.
That is correct. And this is Christina Medina from DentaQuest. So we can get you over the contact information for, we actually have multiple dental directors in case we ever have like an independent review case or something like that. We have like, different eyes and individuals available in case we need to do any type of reconsideration. So we can send you the information for Dr. Thomas, Dr. Bonet, and our staff.
Who is
And are these licensed dentists in the state of Kentucky? That's my understanding that the contract says these need to be
Yes,
licensed
absolutely.
providers.
Yes,
Perfect.
yeah.
Thank you. Yeah, I'd love to have those so I can at least relay those when people ask.
Oh, sure, absolutely. And like I said, we have multiple individuals. So, like that, again, we have a full staff for you guys.
So who would that be? Would that be you have them set up as regional directors, or do you have a main state director with sub-regional directors?
Correct. Yes.
So who would be the main state director?
Dr. Thomas.
Dr. Thomas?
Yeah.
Okay. And then his contact name, his information and everything, can you get that to the TAC members by, let's say, the end of next week?
Oh yeah, absolutely. We'll shoot for, Monday, Tuesday.
Okay.
Absolutely.
Chelsea, is that something we can do of all the MCOs to be able to send the TAC, their dental director contact information and names, you think? Or
Yeah, I'll still look at it and see if it might be in our directory.
that's what I was thinking.
Yeah, so if it's in the directory, we should be able to get that.
Okay. Thank you.
Yep, no problem.
And you can just send that to Barb and Danny, and they can send that to the TAC.
I would do
Is there any more questions on the old business on the dental directors on the compliance of that issue right now? Or any more follow-up that needs to be addressed by TAC members on that? Seeing none, I know there was a and now I know this was, and I could not find it in contracts I had reviewed, and I did not know if, forgive me if I pronounce it wrong, Miss Aggie, Chelsea Aggie? Aggie?
it.
Aggie, I apologize.
No, that's all right.
I know you had looked up last time, and I know you said you didn't have the contract in front of you, but you said there was a 30-day or 60-day notice on those kinds of larger changes that the MCOs had to issue. Were you able to find out, or do you know if that was a 30 or 60-day notice that they had to issue?
Let me pull that up if you don't mind real quick.
No, that is not a problem.
So that I can find it directly in the contract.
That is not a problem at all. I knew we discussed that, and you were going to look that up if you could find it there. So that would be much appreciated. Thank you. And the other thing I know we had talked about following while she's looking for that is there was mention of new pathology codes that were going to be issued, and I know there was. Dr. Kalasa had volunteered to review some of those codes since he does a lot of pathology and soft tissue and hard tissue pathology results. Have you heard anything about those codes, Dr. Kalasa?
I have not.
Okay. So, do we have any status of those codes being issued or what are looking at being issued?
Absolutely. So those are on the proposed fee schedule for 2026. That fee schedule is in the process right now of going through its different stages of approval. As you all know, we had talked about rates several times, and so we did kind of a full review of rates, looking at all the multiple codes that are, the payment is way high on. On the dental fee schedule, and trying to bring those back to what the average is around states around us, and then looking at some of the codes that are slightly below average, based on the states around us and bringing those up to average as well. So we're working on that. And as soon as we get that through, all the approval process, I can't go over in detail because it hasn't been approved yet, but as soon as we get that approved, we'll have that uploaded and online as soon as possible. And because those pathology codes are fairly new, if there's any additional codes that you all would like to see on there, if there's anything that we missed, please feel free to reach out and let us know. And we can probably, for those specific pathology codes, I could probably go ahead and send you those so that you all could kind of get a look at them with the understanding that those are that it's preliminary and it's just from what I'm looking for is your all suggestions and not a guarantee that they're going to be on there or anything like that. Would that be something that you'd be interested in?
Very much. I had gotten an email after we kind of mentioned that last time. The only
Yeah.
codes I had received were from, let me pull that email here.
Get some codes from Ashley Medeiros, maybe.
We got some codes from Ashley Medeiros for a D0461 and a D6049, which was one of some of the things I was going to address in the new business, but that was the only codes that I had seen that was emailed. That's why I didn't know if those codes went directly to Dr. Colassa or not.
No, those I don't know. I have to ask Ashley. Those I'm not sure all the different pathology codes that we were adding, but I'll have her send that kind of an updated listing, and then maybe you all can help me distribute those and get me some comments back within a few days or something like that. Would that be something that would work?
Sure.
All right. I will have I'll tell you what, I'll just have Ashley send those to you, Barb. Ashley, you're on the call.
Yes,
So if you
yes.
can send all
So
the pathology codes that we're going to add to Barb and she can send them out to the TAC.
okay, in regards to the D7285 and D7286, those codes are currently on the fee schedule for general dentists and oral pathologists as well. So they are currently on there.
Yeah, I know we added some though, right? We were, or no, I'm sorry. We had proposed to add some.
Yes, for the pricing that I had sent out, yes.
So, was it just those two codes?
Yes, yeah, those were the new codes for this year. Like I said, the pathology codes that I had email correspondence on was the D7285 and the D7286, and those are currently already on the fee schedule.
So then the ones that you're proposing or that we're proposing D0461, D0469, were those the only two, or do you remember off the top of your head?
Yes, sir. Yeah, those were the new codes from CMS this year.
Okay, so if y'all have any additional that aren't currently on there for dentists, we would love to hear back. And so if you already have those two, I guess there's no need to actually send those out. But
And I was curious, where did those codes come from, you said?
I think
That
those were
is,
new.
oh, I'm
Yeah,
sorry.
no, go ahead.
From CMS, they send when they send out the new codes that are added, that we get a list of all the new codes from the American Dental Association that have been added, removed, or updated. So those were codes. We went through all the codes, and those were the codes that we discussed with management, and they had decided to add those two codes.
Okay. That is what I was wondering is who picked the codes to try to add, because obviously, as from an ADA standpoint on a code list, when they update or take away codes, that goes across the board. But why those two specific codes? Who chose those codes? That's what I was trying to get at. Who gave that information?
We just go, like I said, we go through the codes that are added, and suggestions are sent up to management, and they make the final call. So those were the ones that we made the final call on.
Justin, you mentioned us not, you said this was still under review. Why are we not part of the review process? I guess we're the technical advisory committee. It would seem like if you were making large changes, especially you're considering what it sounds like several cuts, to have input from providers, and you have a committee here. I would just be curious why that we have to wait till that process is over and we're not part of that process. My understanding was that's what this committee was to be involved with.
No, you're correct partially on what you said. So there's not going to be any cuts. We didn't receive any additional funding in the budget, as you all probably know. So we're not making any cuts, but we're not really increasing expenditures also either. We're simply looking at your all's concerns that you all brought forward multiple times in different organizations on some of the codes that are behind in fees. And we looked at some of the codes that are extremely high in fees, way over what they should be. Our managed care organizations partners have brought those to our attention over the years, and so we're just trying to kind of level everything out to where it is all within other states' averages. So when the actual amount that is exactly the same, there's not going to be any kind of cut. You're just going to see an increase in some codes and a decrease in some codes.
Sure. And I guess you're taking input from the MCOs, but not the TAC on those codes.
No, we're not taking, I mean, they pointed some of those out, but no, when we looked at the fee schedule, we just pulled all the different states that surround us, looked at what the average is. We included Delta Dental, they're one of the biggest private providers. And then we looked at our own fee schedule and looked at ones that were way above average or below average. And so that's kind of what we did. We didn't, again, so the way that all the other tax work with fee schedules. You have to understand, as soon as we get those listings from CMS, we are in an extreme time crunch delay to get those done and out. There's not really a time for a review process for that. The time for code reviews and suggestions from the Technical Advisory Committee, which we receive from every other committee, from the physician's TAC, the hospital TAC, every other TAC that's out there, is throughout the year. So throughout the year, tax will say, hey, this code needs to be added. The limitation on this code needs to be increased. The prior authorization for this code needs to be removed. You all need to remove this code. It's no longer used or needed. There's a better code for it. The price on this code is grossly too low. We can't afford to do this procedure with this price. Those are the kind of suggestions we get all throughout the year. So when we get that fee schedule, the first step is we receive, the first step is our TAC recommendations. So we get recommendations from the Technical Advisory Committee. We get recommendations from professional organizations such as, the Kentucky Dental Association, those type of groups, and then individual providers as well. Individual providers will reach out throughout the year. And so our subject matter expert has a listing of every single suggestion that has came in from each technical advisory committee. Sometimes we get those from legislators. We get them from individual providers. We get them from members sometimes who have had issues getting service. One of the changes, and just kind of give you all an example. And again, this is, I'm not saying that this is going to be added, but one of the suggestions that we gave. Right now, you go into a dental office and you try to get some dentures, and we'll pay for that if you send the dentures off to a lab. But if you try to make the dentures yourself, if you're credentialed in your office, we don't pay for some of those codes. And so we had some members reach out and say, "Hey, I'm having trouble getting the dentures here at my dentist. He has to send these out to a lab. I have to go to a different person." So those are some of the things we try to fix from information we get back from specific members too. So we get information all throughout the year from all different types of sources, and then that's the starting point for the fee schedule. When we get the information from CMS, here's the new codes that we're adding, and here's the codes that we're deleting. So we have to look and see which codes are being deleted, which codes are replacing those, and then we put those together with all the different suggestions that we've gotten throughout the year. We have to put that into our system, see how much that's going to cost our system to fix and implement. Then we have to send that through a financial audit to see how much increase that's going to be fiscally. And then we send that up through management and leadership for approval on those changes. Once we get that, we have to implement it. We put it out on the internet immediately. And when that happens, the managed care organizations are notified. They change their system retro their system back to January 1st. We change our system, which takes a little longer, unfortunately, than the managed care organizations. Our system's not quite as good, but we eventually get there. So that's kind of the process. There's just not any time in there to be able to send that, because I can't send anything until it's finalized. So, but throughout the year, we want, and we do get, multiple suggestions from all of our other TACs about codes and limitations, prior authorizations, and we encourage you all to do the exact same thing.
Now, my question, just being new to this, that um, in the processes and trying to learn the process more, you often hear this referred to as subject matter experts and management and things. Who are these subject matter experts?
So the ones that you mean the ones that manage the fee schedule?
Yeah. I mean, because it's like we said, you seem like if you have a whole committee of subject matter experts in that sense, so that can tell you we're in the trenches, we're doing this every day through the TAC. These are the codes we're seeing. These are the things that are going on. So from a review standpoint going forward, it seems like, well, you have every specialty almost represented, all these things, but yet there's a subject matter expert. Who is this subject? And not necessarily by name, but you know, is this a dentist that's licensed in Kentucky that practices? Is this an actuary who just looks at numbers? Is this what? Who is it?
Sure. So it's a multi-part process. The first step, we rely on our providers. We rely, and part of that is the dental tech. So like for other techs, for example, uh, we rely on a lot of our information to come from them. So the other techs will provide, like I said, throughout the year, their review of that fee schedule. Anything that needs to be changed, anything that needs to be added, we get that from our members, our partners. The subject matter expert on our side, there's going to be multiple ones. So you're going to have one for the actual state government administration part of it, right? The policy and procedure part. You're going to have another one that looks at the fiscal part, and then you're going to have leadership, which looks at the overall picture of things. All of the technical dental clinician part, just like with any other of our fee schedules, with physicians, with hospitals, all of our other medical supplies, equipment, appliances. The technical part is going to come from the clinician side. It's going to come from our tax and our providers and our managed care organizations. All those different parts that submit throughout the year issues with that fee schedule. Does that make sense?
Yeah, that makes a little more sense because that, like I said, oftentimes it's mentioned. Well, our subject matter expert
Sure.
decided on that fee to add, and then you have TAC members going, "Why this fee? Where did this fee come from?"
Right. So it either comes from one of two places, right? So our policy and procedure subject matter experts are not dentists. They're not clinicians. So they're never going to look and say, "Hey, I think I'm going to add this code because I think it'll help people." That's not their job. Their job is to take the input that we receive from you all, right? From our tax, from our other providers, from our members, from our managed care organization partners, from the different associations that represent you all. We get those all throughout the year. And like I said, the start of the fee schedule process is taking all of that information and applying it to that fee schedule. And then sending that up. And now, of course, there's going to be things, there's going to be code additions, there's going to be price increases that when we put that through that fiscal analysis, if we don't have additional funding from the legislature that we can't implement, unfortunately, but we do our best to do everything that we can. Another part of that is making sure that the codes that are repealed from CMS are removed and the codes that are added from CMS are added. So there's not a code that's added or a code that's removed that we didn't get some type of provider or specialty input from it from the beginning.
Well, I think as a TAC, we will be more diligent, and I apologize for us not having a greater role with you in our discussion on codes, their appropriateness or not, and the appropriateness of the fee or not. As you remember from our last meeting, we had the beginnings of putting forth a recommendation to the MAC for the TAC to be involved in such fee decisions, and we're later in this meeting, I'm sure, going to bring that up again and go forward with that. So we will certainly be more involved than we have been in this discussion, especially in that it is your year-long peak of interest that culminates in this final that is still nebulous to us. A concern that I do have with that is we completely understand that there is only so much of the pie, and the pie is what the pie is. I I have concern that budgetary decisions on what codes and fees are being moved up, down, in any direction is seemingly, because of our lack of being having a greater role, seemingly be done on an actuarial scale than it is on a clinician being involved with that. Specifically with that, I would have great concern with just looking at averages of adjacent states, primarily because many of the codes and things that we have, one, we have a different population than a number of our adjacent states. And two, apologies. Two, we sorry, that threw me. One, we have different population, but two, we also have different statutes, and those different statutes create a very different program, especially when we have aspects of prior authorization and what clinicians go through for care. Close to home for me is orthodontics. I think we have one of the most stringent prior authorization of any part of dentistry, and certainly in Kentucky, while other states may or may not have that. They also have different stipulations on age levels and what is covered and what is not covered. So to simply compare apples and oranges doesn't really work when we're trying to figure this out, trying to have the appropriate fees. That falls, as we now are clear, on us to make that to have the clinical side be a part of that conversation. But without our input, I don't see how we're having a apples and apples conversation as opposed to apples and oranges.
Well, I mean, that's a good point. There are a lot of things to look at. You have to look at, everything when it comes to fees and rates, right? And so that's what we try to do. But again, that's what we rely on you all to do too. We have conversations throughout the year with each of our TACs, each of our TAC members, from other TACs on, codes, code additions, limitations, prior authorizations. I mean, that's pretty regular. That's an almost daily occurrence that we have, and it gives us time between fee schedule changes to kind of hash those out. A lot of times we will meet with individual providers, provider groups, whether they're the TAC or an association. We'll meet with some of the managed care organizations too. We can go through that, so it gives us time to really kind of hash out any major issues that we have. I don't see a lot of, we don't get a lot of those things, a whole lot from dental, on the dental side of it. And again, we get a lot from providers. We get a lot from your individual providers. We get a lot from members at times. Yeah, we definitely encourage the TAC to bring any of those issues, that you have to us and have those conversations.
Well, being the shockingly longest serving TAC member of this group, I apologize for us not being more proactive, and we certainly will be going forward. I do want to get some understanding of, as we work through things through their MOAB and potential increase of that pie for dentistry coming aboard. How would you say DMS will look at those fee schedules at that point, and what involvement the TAC would have potentially in those changes?
So if I understand your question correct, you mean if there's an increase in funding for dental specifically? Is that right?
Yes, sir.
So, that I'm trying to think the last time we had an increase, what provider group, but the last time that we did that, where the legislature provided extra funding for a group, we used that TAC predominantly. We used the TAC and their association as two of the work groups that put forth suggestions on where that money was to go, what codes increased, what rates increased. I think there were some services added. So, I mean, you all are our, sounding board when it comes to those types of decisions for us here in DMS. So you all would play a predominant role in your recommendations. Um, that's usually who we bounce ideas off of if we're increasing, certain rates according to extra money that we got from the legislature. You all are kind of you are the representatives for providers for dental. So, and we try here at DMS to use you as that way. And I apologize if we haven't, sent more things for you to look at, for you to comment on. Um, we get really we get less from the dental tech, I would say, and overall dental as far as suggestions and specifics on the fee schedule. But looking back over the last several years, I mean, a lot of our changes that we've made have pretty dramatically came. I mean, we've got a lot, and we'd have to look back at the minutes. But over the last several fee schedules, we've made a lot of changes due to dental tech suggestions, a whole lot. So, some have come from the associations. And again, like this year, we've got a couple that just came from members that were having trouble getting services. And we realized we're not paying for these things that we should be. But, that has came from previous tax quite a bit. And again, another tax, that's where we get a lot of our suggested changes from.
What would be the formal process with that, Justin? Is that through our TAC meetings, or is that outside of the TAC meeting in suggestions from the TAC directly to you or to DMA?
Either one. So you all are more than welcome to reach out to Danny now at this point at any time and say, hey, we've got questions, we have recommendations, we have an issue with this code. And you can do that immediately through Danny. She's your point of contact to reach out to DMS. And then if you don't get an answer in time, be sure to put it on your agenda. That's why it's important, again, to make sure to kind of list it out on the agenda so we make sure that we are prepared to have everything we need for each TAC meeting, that we have the correct people on the calls, those type things. And in case, you don't get an answer back in time, but that just really opens up. We have, and again, I kind of apologize that we don't have this for every TAC. It's probably something we need, but we have standing meetings with members from the physicians TAC, the therapy TAC, the MSEA group, that are in between the TAC meetings where we can address issues like that. Where if we have a problem or issue that comes up, we can kind of tackle it immediately. Or if it's a problem that needs to wait to the fee schedule, something like that, then we talk about it, hash it out, research it, that kind of thing. So yeah, Danny, if you could put your contact information in the chat, that would be great.
I'd love to have a
Absolutely, I sure
volunteer
can.
in between meeting, by the way. I would volunteer first.
Yeah, no, I think that's good. We'll go ahead and set that up. Like I said, we have one with several other techs where it's very informal. We just kind of talk about some issues and try to work on those because again, you all are our clinicians. We don't have the budget to hire a specialist for every single. We have just in my division alone, we have over 76 provider types. And then there's sub provider types to all those 76 provider types. So to be able to hire a clinician for each group is just not feasible. So what we do is we use our TACs, we use our providers, we use our MCOs as our clinical experts on any issues that you all are having with the fee schedule. If you're having an issue with something and it's not and sometimes it gets handled on the back end too, that where you all might not see. A lot of times the managed care organizations will come to us and say, hey, we're having this issue with this provider. We're not able to bill. We're running into issue where we have, a limit of 2 services for this, and we think we really need 3. So that happens a lot too. But we'll set that up. I think that would be great. Dental's becoming more prominent, and so I think it would be a positive step moving forward. We'll get that set up and do some informal meetings in between these meetings.
I think that would be a good something good. I know, Caitlin, you had your hand up a second ago.
Yeah, I just have one quick follow-up question when you were mentioning about members reaching out and other individual dentists that aren't on the TAC. What is the best way for us to advise a patient or another dentist if they're not sure how to make those suggestions throughout the year? Do you want those to come through us to the TAC, or if they would like to suggest that individually, what's the best way to do that for them?
Either way, I'm gonna put an email.
Okay.
And this is where well, I don't, that's not really true. This would be the email that you can give out to anybody
Okay.
that has any provider, any member,
Okay.
anybody that has an issue. And we'll get them to where they need to go. You know, it just depends on what, a lot of times it'll be somebody that has a managed care organization that, you know, they're just looking for a dentist that will direct them to their MCO to help them find a dentist. Maybe it's somebody that has a question about a service that they're having trouble with, like the dental or the denture issue that I was telling you about earlier. But we get stuff in that inbox. We get funneled stuff from the Office of the Ombudsmans. We get it from all the different legislators that they all send stuff there. We get stuff through CHFS Listens, all the different public emails and calls. So what they'll do is when somebody calls, they'll take a message and they'll put that in email form and send that to that email box as well. So we get them from all over, and then we'll send those to who they need to go to. And if it is a suggestion on a code addition or a limitation change or a prior authorization change, or whatever, that goes again to my division, and it goes in that group of when fee schedules open. These are one of the things the first things that we look at.
Thank you.
Absolutely.
And Justin, I appreciate you so much being open about it because, like I said, with new members, we are drastically trying to play catch up and learn a lot of these processes. So,
Sure. Yeah. No, absolutely. And you know, probably some of on my part, you know, something that we probably need to do, Danny and Barb, make sure that we talk later. We probably need to have like a new TAC orientation that goes through some of these things.
Hey,
You know,
Justin.
yes.
Sorry, this is Erin. There
Yeah.
is a new member orientation packet.
Well, yeah, no, you're right. Miss Bickers is correct. It doesn't have some of the things that I'm talking about today because I neglected to add any of it. I apologize. Things just like this, like where to send stuff to, you know, what types of things should you be looking at and sending us, those type things, that I have neglected to put in there for you all. So, I will work on getting those things in there too.
and Miss Big, I think you said there was a packet for that. I know I had never gotten one. If there's a way I could get one, I'd be much appreciated. Um,
Yeah, we had one approved by our senior deputy commissioner, but Justin's group is taking over the MACTAC. So if he wants to put together a different one, I'm gonna his title's bigger than mine, so I'm gonna stand down. But I can send you what I have
No,
if you'd
yeah,
like.
yeah.
Has
Please send that, Miss Bickers.
most all the who, what's, the rules. I do want to mention too, if you have providers, TAC meetings are open to the public. So, and they also do have the right to request agenda items or speak through the chair. So I did want to mention that because I think Caitlin asked questions about if providers also had some input they wanted to share. The TAC meetings are open to the public.
all right, thank you so much. And I know we got off on a little bit of a tangent going there through and with the start of pathology codes and some of the codes that entered into that. I don't think there was any other follow up unless we had an answer on that 30 or 60 day question earlier that if you were able to find that out.
Yes, good afternoon. Yes, thank you. So what I was able to find in our contract in regards to subcontractor changes for MCO partners. So there is not a minimum requirement minimum notification period for providers when subcontractors change with MCOs. The MCOs are required to notify the department within 10 days of their notification to that subcontractor that they're either going to suspend or terminate the contract. But there's not a minimum provider notification requirement within that area. And just to give a little context of why that is, if there's ever a material breach of a contract between an MCO and their subcontractor, that could constitute an immediate termination. There's really no way for them to, pre-notify providers of that happening, if that were to happen. The notification that they do send, once they notify the department, if that subcontractor is, it's like Avisus or DentaQuest, where they contract directly with providers. The MCO has to submit to the department what that provider notification letter is going to say, because any provider or member facing documentation from MCOs has to be pre-approved by the department before it's disseminated. So typically the department has 30 days to review and approve documents. In these types of scenarios, MCOs usually ask for expedited reviews, which have to be completed within 5 business days once the department receives it. So it can be a little challenging to add any type of minimum period there for notification when there's instances where you might have a termination that's immediate or, very abrupt due to some sort of contract breach.
I don't think, correct me if I'm wrong, BJ, I don't think our goal with this question was about sort of outlier situations. It's more about these predicted and scheduled transitions of the MCOs. I think we're referring specifically to how we've kind of gone to several additionals. And I think what we're hoping for maybe is a little bit more lead time notification for us to change credentials, which I think is also on our agenda. So it may be good to address there. But I don't think we're looking for, somebody does something bad or they have to terminate. It's more about like when we kind of went through what we've done with Skygen, DentaQuest, WellCare, all those ones that none of that happened, but about just the predictable things so that we have time to sort of not have patients fall between the cracks, I guess, is what our goal is.
Yeah, I completely understand, and acknowledge what you're saying about, needing that notification and wanting to be able to timely contract and, so I definitely hear that. There's just no carve out in the contract for their subcontractor requirements specific to if this subcontractor is someone that contracts directly with providers. This is the specific scenario where then you would send out this X amount notification period. So that's kind of what it is. It's just not, it's very broad in the contracts. There's no carve out specific to that type of subcontractor. I will say, if you all have a recommendation for contract changes, that is, similar to how you can recommend the fee schedule suggestions to Justin and his group. My branches, we also do take recommendations from TACs about contract changes. So if you all have a recommendation that you would, recommend that there would be a carve out maybe for this particular scenario or type of scenario, then we could definitely, look into that when we're doing our contract amendments.
Thank you very much for finding that out for us.
And I can put our branch inbox in the chat. And if you do have, recommendations, you can send them through there, or you can also send them through Barbara and Aaron.
Okay. And yeah, if you want to put that in there, that would be helpful.
Yeah, I will do that right now.
All right. Thank you so much. And I think that goes through most all the follow-up and old business, unless there is any other old business at this time. Seeing none, moving on to new business. Audits and attempted recoupments. This is always a big topic, and I think has come to a lot of light in some recent things I know I've heard from other providers. Does anybody want to open into that from TAC members?
I can start if no one else has anything. I was kind of looped in on an audit recoupment situation with WellCare Visas from Dr. Bobby Wagner. He's a longtime oral surgeon out in Western Kentucky. I know Dr. Lee, or I mean, excuse me, Lisa Lee and Justin Derringer were also on these emails. I received numerous. I guess there was a lot of frustration from the provider by a lack of communication through Visas and WellCare, which ultimately amounted to a rather large attempted recoupment. Um, Looking at the details of that, to me, I don't know exactly how this stuff works, but it kind of feels like the provider was sent a notification to return money, and then from the numerous emails that I was looped in on, there was very little communication about any sort of recourse. Uh, Basically, it sounds like it was around 30 cases that he took to the OR for full mouth extractions. Those teeth were subsequently extracted, and from what I could tell in the recoupment, they attempted to recoup that down to as though he had not performed those procedures. To me, if the feeling was from a Avisus or WellCare that those procedures, were not performed, that would be kind of fraudulent. Um, but I've known Dr. Wagner for 2 or 3 years now, and I find it very unlikely that those extractions were not performed. So I guess like I don't know if we're trying to maintain a network, and it seems like it was a documentation issue. And there was he had been from this is obviously I'm only hearing from his side because there was no feedback from the other. Was that he had been audited in the past and his documentation was very similar, and there had not been any issue with that documentation. But now, because of some documentation issues, they did a gotcha, and they now are asking for I think they're over north of $40,000. What are we supposed to advise people who are trying to get expand our network or maintain the network when these types of things occur? And I'm part of these email flurries, and I don't even see anything. Um, I guess it's more of a statement of like, can DMS help in these situations, or what's is it just the MCO rules with an iron fist, judge, jury, and that's it? And because it seems to me like the extractions were performed, and to recoup that down to $0, it's odd. So really, just looking for any kind of guidance to provide that provider with those situations.
Oh, hi, good afternoon. This is Dana Flood from Avisis. So this is a letter that came from a FWA concern. And in those communications to the providers, we outline their appeal rights and how to go about that. And so my suggestion, if anyone would come to you, would be to, follow the instructions on the letter, reach out to the contact on the letter that where it specifically explains their appeal rights in those situations and take those steps if they disagree.
I guess my issue with that is the appeal assumes that you all have made the correct judgment to begin with. So they have to appeal I mean, you could send me a letter and say, you just have to send me this money. And so I
Comes
have to
down
go through an
to,
appeal process, whereas he's already provided you the documentation of those procedures.
yeah, the appeal rights outline like the steps to take an appeal, and it's an appeal is truly when you disagree with the decision that has been made. So if he disagrees with the findings from that review, he can appeal with supporting documentation or a narrative, whatever he feels is fit or the person feels is fit to support their appeal in disagreeing with the decision.
Sure. He told me he submitted all those notes,
Yeah.
and those notes subsequently outlined the extractions that were performed. And then that was after an audit, and he basically was told that he did not extract those teeth, was the equivalent of him reimbursing for all those surgeries, although those procedures were performed. I mean, if you want to squabble over what was paid, I get that. But to say that it wasn't performed to me is a totally different thing when he had provided that documentation. But maybe it's just about how certain people do business. But that's just not how I would do it. But I mean, if that's your process, I guess that's your process, and that's what I'll relay back to him. I would just, that's my thing is, this guy's been a provider for you for 20 years, and all of a sudden you want to recoup that. It just, when I believe he performed the procedures, it's bad business, and I would encourage people to be careful when they're dealing with certain MCOs, I guess.
Yeah, as it being an FWA case with our FWA team, I can't speak too much to it, other than I know that those letters include appeal rights, and he has those rights.
And just for the TAC, I mean, anytime that the TAC feels like that there's something that has been done incorrectly, they're more than welcome to reach out to me, to us. You can reach out to Chelsea. That's actually Chelsea's group. So when I get something like that, usually the first thing I do is reach out to Chelsea. And we've looked at that. We've looked at cases all the time. But what we're looking for is to make sure that everything is in compliance with the contract between the provider and the MCO, and that nothing is against DMS policy. Those are the things that we look at on that end of it.
So I'm trying to think here. I guess my question in that, and this is kind of, I guess, the appeals process, in that once again, not knowing this situation and being new to something like this that has been said, I'm assuming Avisus would have had, for whatever reason, a reason to audit what they felt a reason to audit, and that audit would have been performed by a licensed oral surgeon in Kentucky. And I'm just talking in general, not necessarily this specific case. If you were coming to do a general dentist, obviously I would not expect an orthodontist to be looking at my case of an audit and a reason. Can Avisus respond to that? So would that, I guess, need to be something we would need to put as a more follow-up maybe to a dental director for Avisus? Do we have a dental director for Avisus?
I can
Oh, there I can see Dr. Connell down there finally.
I can add to it that piggyback back on what Dana said. The FWA department is totally and completely separate from our clinical department, and that's done intentionally so that there's no undue influence one way or another on these audits. And it was reviewed by a dentist, but I don't know which dentist that was.
And I'm not asking for a specific name, Dr. Cottle. I'm just going, there is I guess you would say, I would assume if it's an oral surgery case, you're having an oral surgeon review, or a general dentist for a general dentist, a pediatric dentist for a pediatric, an orthodontist for an orthodontist. Obviously, I don't think like Dr. Petrie would feel necessarily qualified doing an oral surgeon's case, and I don't think a lot of the Dr. Kloss probably would be feel qualified doing Dr. Petrie's case. I know I would not feel qualified judging their cases. So making sure a peer-to-peer judgment was made, not necessarily a random person. Is that the way Avisus would handle that?
Well, since I don't have a vision into that department, I honestly can't speak to that question.
So you don't know how that works, Dr. Cottle, really?
Again, that department's kept separate from all the dental directors in all of our markets, all of our different states. They don't have a vision directly into that department. Again, it's done intentionally.
Where this was on the posted agenda, is there someone from that department on this call that can answer the question that was posted on the agenda prior to this meeting?
So this is Barbara from DMS, and the agenda was sent out to all of our MCOs.
I guess my biggest concern on something like this is and this is not necessarily even going directly at Avisus. This would be for SkyGen. This would be for DentaQuest. Whoever's managing is making sure an audit is done by peer to peer, not necessarily a random person who's not would not always necessarily be qualified to make certain judgments. Because the way a prosthodontist might write a note or say something is not always the same way a general dentist might exactly say something due to training. To make sure who's looking at notes is an equivalent peer making a judgment call. Would any of the other MCOs care to answer that in their process?
This is Larry Paul. Yeah, SkyGen, our audits are conducted by like providers.
Okay, that's what I'm getting at. Is not saying somebody might need to review or not it, but like providers, if that would be preferred.
Yeah, and this is Christina from DentaQuest, kind of going back to the first in the beginning of the call, talking about the dental right directors. When I mentioned, like, we have several different individuals depending on the need, right, and also ensuring that you know, not only is it an oral surgeon, for instance, in this case, but it's a different oral surgeon, if that makes sense, that would have an objective opinion.
Okay.
And I guess this is even more important because I have a feeling we're going to see more of this fraud, waste, abuse stuff as we go forward with budgetary changes. So I guess this is sort of a preemption to a preemptive request to make sure that we have some transparency with how that works. I mean, if this person tells me they pulled the teeth, if you want to fight over whether that's simple or surgical, totally understand that, documentation. But my understanding of that situation was that it was audited down to that as though those procedures were not performed. I was able to view the documentation because it was sent. And so an orthodontist, no offense, Joe, could look at that and read that the teeth were extracted. So I guess it's just, I don't think, I mean, I guess you sign up for what you have, but it just, I feel like a lot of these providers are acting in good faith and this becomes adversarial. And, I don't think that's what we want this to be when we're trying to take care of these patients. If there's obviously true fraud, sure. But if it's we're mincing words over documentation, is there some way that there could be an intervention before you're like, hey, write me a check to say, hey, this is what we're looking for. This is what you're doing incorrectly when you do these audits, so that it's not this gotcha moment or this adversarial relationship because it doesn't need to be that.
I can comment again, Larry Paul from SkyGen, and I'm involved in our FWA with our SIU team and FWA considerations. We really look at audit as a final resort and look at it only in cases that are, I'll say, egregious. If we find something within our data, primarily we will try to have what we call an inquiry with the provider just to understand, give us an understanding, a consideration of what we see, or some sort of educational call. So those are always our initial steps. Again, unless we see something that's from the outset extremely egregious, we might go directly to audit. That rarely happens. So just a comment on the process at SkyGen.
Adam Rich has his hand up right now.
Hey, yeah, thanks, Dr. Malay. This is Adam Rich. I'm the director, chief dental officer with UHC, and similar to what Larry Paul said, I just wanted to outline our FWA process, our fraud, waste, and abuse process, SIU. Um, you know, basically, it comes down to outliers. We're looking at the data to see if the type of practice is aligning with other providers in the area. If they're not, then we take a closer look and say, hey, why is the provider not within the metrics? And sometimes it's just because of their patient base, or maybe it's the provider's technical expertise and what they want to do. A lot of times it is, some providers are doing full mouth extractions, and general dentists are doing just as many surgical extractions as an oral surgeon. So we take those into consideration. If the provider it does look like, and it more established that they're outside the lines of normal treatment and normal billing, then we're gonna counsel them and advise, hey, you're pushing the limits. You're not with your peers, and if that doesn't change the behavior, then we'll look at prepayment review options. If that doesn't work, the last resort is to cancel the relationship with the provider and move them out of the network. Last resort, and again, only if it's extraordinarily egregious would we recoup, and that's probably if we're advised from the state to do so. So the last thing we want to do is recoup for work done. But that's it. I just want to give a basic outline of how UHC does their fraud, waste, and abuse. And if there's any questions, happy to answer those too.
Thank you, Dr. Rich. Any other issues that people have had with audits or recoupments at this point in time? Seeing none, moving to next new business item, which is Medicaid secondary insurance benefits.
I can take this one, BJ. Thank you. I guess the initial question that I have is one. I've never liked when our TAC is reactionary, but sometimes there are incidents that have to be. We don't have any communication that makes it even more challenging. I have struggled with a situation that's happened in our practice, and I've struggled to get answers as to why it has happened. And I have concern that it is a change that is going forward, may come up again in our practice and in others. And I'm speaking to other providers. It's unclear whether it's happening throughout, or if this is a few instances that we're seeing. I guess I want to ask for DMS when there is if we're looking at orthodontics, and let's just take comprehensive orthodontics as the case, and we have a private insurance with a patient who is approved for comprehensive orthodontics, I have struggled to find in writing DMS's policy on that and what is to happen and what does happen. I know what has happened in the program since my involvement with it going back to 2005, but I'm wondering what the official stance is on on payment as it relates to patients that are in the comprehensive orthodontics and a private insurance is also involved.
Justin, you want me to take this one?
Yes, ma'am. That is your area of expertise. So go right ahead.
Okay. This is excuse me. This is Teresa Shields. So if you have a patient that has commercial insurance, and I might have misunderstood part of your question. The commercial insurance must pay first and then Medicaid. So what did I miss about your question? I'm sorry, doctor.
No, you're dead on it, and that has been my understanding of the program going back to how it was well back when Dad was doing this at the beginning of the program, and since I have started in '05 and then with him in '08, that the commercial insurance paid first. So let's just take an example. If the commercial insurance, if the fee for the orthodontics, let's do round numbers, was $3,000, and Delta Dental had a max benefit of 1,000, how will that claim be paid out?
Okay. The way it's paid is you bill 3,000 to Delta Dental and they pay 1,000. So that leaves 2,000 left. So when Medicaid is billed, it shows the 3,000 billed amount. It shows the 1,000 from Delta Dental. And then here we go back to codes. Whatever the fee schedule is for that code, Medicaid will pay up to that amount. So there's $2,000 left, and whatever that code might be, say Medicaid, their fee schedule is $1,000. So Medicaid's going to pay 1,000 of that $2,000 that's left.
Thank you. I'm sorry for walking you through something that seemed so simple.
No, sir. No, sir.
So
Not at all.
Medicaid will pay out to the contracted amount through Medicaid, which would be the $3,000. Can I get something in writing, or is there a place you can direct me to see that in writing?
Okay, you said contracted amount, and we're paying up to our fee schedule.
Fee schedule. Thank you. Yes.
Okay.
Even better.
Okay. I'm sorry. Okay, I just
No,
want to make
no.
sure.
I apologize for the soliloquy. This will hopefully make sense in a moment. What is the expectation with MCOs? Is it the same, or what is the understanding there?
No, sir, it should be the same. Once MCO is billed to $3,000 and the provider shows Delta Dental paid 1,000, there's going to be $2,000, and then whatever that fee schedule is, they should pay up to their fee schedule amount.
Yeah, and I just want to caveat really quick by saying it is so Ms. Shields 100% correct when she says fee schedule. We're talking about fee for service, but as you all
I'm sorry.
know,
Yeah.
when we're talking about MCOs, it's their fee schedule they've negotiated with you in their contract. It would be that amount, not the fee for service fee schedule specifically. Hopefully that makes sense.
That does make sense. I have not had an issue with DMS with this, but I've had a difficulty finding through DMS how the language that is the way that is supposed to be. As I and my billing team and any orthodontist that has been part of the program has understood it to be for years. Recently, one of the MCOs has, on not all cases, but on a few cases, rejected the fee and stating that they only pay up to the maximum benefit of the private insurance, i.e., if Delta has $1,000 benefit on a $3,000 case and they end up only paying $750, that the MCO only will pay the additional $250. Everyone on this call knows that's incorrect. But that's what we've been told. And we have been told if we don't agree with that, we can appeal that. I think that's ridiculous, which my staff has already been doing. The lack of response from providers, provider relations in this instance, especially in that we don't have a dedicated provider relation for our region right now. But the lack of response from provider relations in this is challenging. The response that the claims department says, no, this is how that should have been paid out, and it is correct. is concerning because clearly, as was so succinctly stated, DMS understands it. The MCO has understood it for years, and I don't understand what the change has been. And frankly, I'm extremely frustrated with the lack of even a response to emails to individuals in the MCO, even up to the level of the dental director of the MCOs, just not responding to emails on this. This is not something that needs to be in front of the TAC. This is something that should have been addressed very quickly and easily. Said, no, they're doing that wrong. But this is where we sit, and I just wanted some clarity there.
Justin, is it okay? I'm sorry. All I see is Dr. Joe. I don't see his last name. If he could send the specifics to Danny, and then Danny can send it to Chelsea and me so we can both look at it and get a response back.
Absolutely. That'd be great.
Thank you.
Thank you. I appreciate that.
You're welcome. Anything else about dental and TPL?
No, I think that's seeing none. Moving on to the next new business topic, which is lack of dental directors or acting directors, or contacts of an acting director for temporary purposes when there is no dental director. It does sound like, I know, of course, that's always been an issue with Skygen we've been worried about. I know they have tried to fill some roles, and it sounds like they are finally getting a dental director in place there. Any TAC members want to address or Dr. Petrie, you cut out there.
I think we did I'm sorry. I think we did a good job initially in this meeting talking about that, and I'm glad to hear Dr. Elliott coming on board. And I think the interim director has done well with questions through the TAC and for individuals. So that's good to hear. I would hope that all dental directors will respond in kind to contacts, especially from TAC members, but to all members that are in contact with them. But unfortunately, that has not been all of our experience. With this, beyond what we talked about MCO dental directors, I think the TAC also has some questions about where we stand as far as a state dental director, as that position has not been filled. I don't believe since Dr. Rich was in that position, but still yet it's been a while, even if someone's been since him, where we stand on a state dental director for DMS.
So DMS does not have a state dental director at this time. I don't know if there's plans in the, I think there are, there would be scenarios looking at some of the potential legislation that's out there where that would become a priority, but I don't think that that's something that that we're looking at right now.
Okay, thank you. I think we see the potential of things in the future needing strong leadership from the state. And Justin, we're ready for you to be that go-to and that leader for us. But we also know that a dental director would be a big help for you guys and providers.
You know, you're correct. I mean, I would love, again, like I said, we have, you know, over 70 provider types, and each of those provider types have multiple specialties associated with them, and as many of those clinicians that we could have. I mean, you know, that would be great. I think we have two medical directors currently on staff, and I know that they would love to have more help too, because I wear them out constantly. So, yeah, that would be amazing. So maybe we can get some more funding coming up, and we can add you know, a dental director, and we can add some other providers, some other clinicians too. That would be amazing. I welcome it.
I think that's oftentimes one of the things we look at is that additional person to help. Seems a lot of these questions and oftentimes seems like to be headed off by that position. And I think that's one thing we, as a TAC, have some concerns and hopes for because that really would help direct a lot of things, especially staying in standard with MCOs, having that as part of their contract, having a dental director, and then the state continuing that example in that front to help manage those MCOs from the dental standpoint. Any other issues right now dealing with dental directors? Like I said, I know I'm glad to hear Dr. Elliott and SkyGen. That is a big help. I know DentaQuest said they were going to have theirs put together, and hopefully we'll have that list through next week. Any other issues right now or concerns? Dr. Klossa, I saw you come unmute.
I would just want to say something positive to Larry Paul, since I seem to be the negative one today. Dr. Tran has been fantastic for me to work with through SkyGen in the interim. I know it's a little different, but I just wanted to give him a shout out because he's always been extremely responsive to me and answering questions and you know I have a lot of them. So I just wanted to say something positive about the interim you did have in place, at least in my experience, Larry.
It's always good to get positive feedback, and yeah, I agree with you. I think Dr. Tran's done a great job. I'm sure he's on the call here, so he gets to hear it. But yeah, thanks for that.
I appreciate it, Doc, and made my day.
So looking at network adequacy was the next new business topic, and I know that's a big topic for all of us. Does anyone open up into that topic, or because I know one thing we're looking at is failing network maintaining providers within the network, and looking how network adequacy is judged. I know per contracts, network adequacy is often looked to and determined by the MCOs themselves. And I think most of us can vouch for the fact that if we call to find a provider or somebody's calling our office, oftentimes you're the 8th or 9th person we've called and nobody's taking my insurance, or we are not on network and we have a specialist calling, are you taking this insurance? Or calling a specialist, are you taking this insurance? So we're basically letting the MCOs, determine their network. How do you know true adequacy of a network? And I know the state has been looking at some of those aspects and doing some reviews. Is there any input, I guess, from the state to determine as a third party, I guess you would argue a secondary party or third party, what the true network adequacy is for those MCOs?
Just to add a little, I've got a hand raised too, but just to add another to that, BJ, is just to simplify it. And one of those aspects is that while there may be providers listed, if providers aren't accepting new patients, then they're not a network. And so that's something that we're seeing. We're seeing even if there are providers within a 30 or 50-mile radius, depending on if you're metro or rural. If those providers, one, are the same people, then you can't count them twice. But two, if they are not accepting new patients, then that's not providing an adequate network.
Chelsea, I see you have your hand raised.
Yeah, good afternoon. So I did wanted to just add a little bit of information about one thing that my branch is working with the quality branch DMS on. We have a report that MCOs submit quarterly. It's the PSN 12. That's the report name that we refer to it as, and it is a network adequacy report. And what we are doing is each quarter we are asking MCOs to report on a different provider type. And what they have to do is any providers that that are not or have not submitted claims within 365 days, they have to outreach to those providers to determine if they are still wanting, wanting to be in network, get an explanation about why they haven't, produced any claims in 365 days. Sometime, and then they have to report that back on that report to DMS, what the rationale is for what they found and why that provider has not been billing. So we are identifying through this first round. We actually did dental as the first provider type because we recognize that, there is challenges in Kentucky with dental providers and network adequacy. So when we received those reports at the end of last year, our quality team did a real deep dive in the data. And we actually submitted some corrective action plans to all of our MCO partners with our findings. So they are set to work on those corrective action plans throughout the next 6 months. And they have to report back to us in 6 months and a follow-up to the department's feedback. So one thing I did hear you mention was not accepting new patients, and that is something that DMS has discussed with MCO partners. When it comes to network adequacy, if I'm a member and I'm not able to pick up the phone and call and get a dental appointment within within the mile radius that's required, because that provider is not accepting new patients, I don't consider that fulfilling the needs of the network. So we did identify where there were instances where providers said they do not accept patients. So we are asking MCOs, you have to remove those providers from your network adequacy. That is our recommendation because they are not truly meeting the network requirements of any provider, any willing provider. So, that is one thing that we're currently in the process of working with the MCOs on. As I said, we should get an update in June this year, I believe, for their follow-up to see how they handled those providers, making sure that they removed the providers who were no longer active from the network directories, and as well as the providers who have closed panels.
Dr. Cruz, you have your hand up.
Yeah, one question for you, Chelsea, would be, is that information that we could see then of the network adequacy and the providers that are or are not providing care? Could you speak on that?
I would have to double check on that because it may come to be like a type of ORR. So I can take that question back to determine what we could share. We may not be able to share individual specific provider data per se, but we may be able to share as far as, percentages or regions, what we're finding in each area.
Dr. Colasa?
Well, I've got some real I'm sorry, Justin. I've got some real concerns with the network adequacy thing. I sit down in Owensboro, Kentucky. We're about, 100,000 folks in our county. And we don't even have a general dentist who accepts any form of Medicaid. So when some of these MCOs are saying they have a network within the state or within a county, we're just not seeing it. I don't know how many patients a day that we are forced to turn away because there's nobody around. As a pediatric dentist, I'm doing general dentistry all day long. I'm working on 16 to 20-year-olds because there's nobody else to do it. So I would just really like to be able to see something from either the MCOs or from DMS that's going to show us exactly what this network is, because I just don't see it.
Yeah, I definitely hear the frustration, and I understand where you're coming from, and we will try to be as transparent as possible with what the findings are. And I do see Rachel Rohrig, who has been helping with this effort, has her hand raised. So I want to allow her if you have something to add, Rachel.
Yeah, absolutely. Thank you. And Chelsea, you said it exactly on the intention of the creation of the report, what our goal is, the steps that we're taking. And Jay, to your point, that's exactly what we're finding. And the kind of information from each MCO on, you say that these providers are in your network, but then when they haven't billed and we require you to reach out, come to find out they stopped seeing Medicaid members 2 years ago, 3 years ago, but it never went back up the chain to the MCO and all the steps that it needed to take. So the numbers that we were getting were not matching the true experience of the member. So we definitely noticed that mismatch, and that is something we are absolutely taking on board, starting with dental. So I'm so glad that this is on the agenda and that you brought this up, because this is a huge endeavor for Division of Quality and Population Health and coordinating with our other divisions within DMS. And we're starting to see a lot of dissecting it out to get the true information before we can move forward with a solution, really dissect it out to see what the problem is, where the problems are, so that way we can approach it in a very strategic way.
And
Thank you.
correct me if I'm wrong, but and I may, but it's a multi-division kind of task. I know we Rachel's group, Chelsea's group, both working on it quite a bit. But even in provider enrollment, they're working on a way to incorporate into the renewal process. Are you currently, some questions like, are you currently billing for Medicaid services, and are you currently accepting new Medicaid members into that process, so that each year that regenerates? And there's a report that they're working on, a provider directory that they're working on that shows you which providers accept Medicaid. They're working on showing which MCOs they take. They're working on it showing are they currently accepting new Medicaid members. So a lot of work going on around this specific topic in multiple divisions throughout the department.
Dr. Kloss, I know you've had your hand up.
Thank you. Yeah, I just had a couple questions. I really appreciate that. Then you guys looking at dental first. I guess I would ask, are we able to see what form you send to the MCOs for those questions? And then I guess if I had that, this would answer the question. When you look at those, is it subjective information that's given to you back from the MCOs, or are you looking at, like, say, a threshold of established visits? They've done 100 or 500 or 1,000 to sort of say, well, I'm accepting new patients, but maybe they did 10 new visits. Is there objective data that's not subjectively reported to you from the MCOs that you can evaluate in their networks to objectively assess that? And then the other question I had would be the corrective actions that you've put forth, even if you don't specifically give us which MCO you gave those to, could you provide those so that we know what those corrective actions have been asked of, so that we can be on the lookout for it?
To answer the first question about the data, I unfortunately would have to defer to Rachel. She is in the quality branch, and she actually, worked with the quality group to analyze the data once it came in. So I would have to defer to her. I did just see she had to drop for another meeting. I'm happy to follow up with her, and we can provide you all a follow-up response after the meeting today, just to explain kind of how we've reviewed the data. And then as far as the corrective action plans, typically those have to be requested. Like, if you wanted a copy of the corrective action plan, you can request them through an open record request. But we might be able to at least give you some information about what we found and kind of our line of questioning, and how we are asking the MCOs to work on providing that supplemental data.
Thank you.
I'm sorry, apologize, Dr. Kloss. Dr. Petrie? So say, Joe, you have your hand up. There it is.
Yeah, sorry, it took me a second to get the unmute to happen. This may be working to put a bow on this unless we have more with it. But I'm so pleased that you all are looking into this, and this is something that has been it's been a large topic on the MOAB, and it's a large topic on these TAC meetings. A year or more ago, we were pushing that we had issues with network adequacy, and we were talking about oral surgery and not being able to get folks to oral surgeons in my neck of the woods in East Kentucky for 9 months, sometimes even further out for any type of care, and how that was such a detriment to their health and was leading to long-term negative outcomes. We've been beating this drum that the network is inadequate, no matter what we're being told by whomever is looking at it. And that started with looking at oral surgery. Well, now we're looking at it, as Jay points out, we're looking at it in general dentistry, and we're looking at it pediatric dentistry and orthodontics, all the specialties. But when we're dealing with, even in a city the size of Somerset, well, I'm not talking about Far East Kentucky, because that's a whole nother exacerbated issue. But even in a city the size of Somerset, we're struggling finding providers and getting patients in that are in active decay within 6 months. And in 6 months, you go from sending a patient, as an orthodontist, you go from sending a patient for active decay to, at bare minimum, a root canal, which exacerbates the system more, adding on an additional issue there, an additional claim, to them seeing Justin to pull the tooth, which has all of its negative sequelae simply because we don't have an adequate network. I'll carry that on to Jay's point. We have very few pediatric dentists in East Kentucky. We have very few near the 75 corridor. We have a decent amount in Somerset and West, but they are so inundated that patients can't graduate out from them, which is a challenge because they are teenagers and beyond. As Jay will tell you, they're 20-year-olds that he really should not have in his office, but he has to because he doesn't have a place for them to go. So the adequacy that someone is seeing them, but it's the wrong person and it's the wrong time. And those patients, some are being scooted out the door from the pediatric dentist just because there's no other, they cannot manage their practice if they don't. And then we have patients, in my case, in active orthodontic care, that are graduated out of the pediatric dentist's office that then don't have a general dentist, and then we can't find a provider for them. And many of these, we're looking again at foster kids, or we're looking at parents that are incapable of driving them from Somerset to Corbin, in essence, to get care, or driving from Hazard to Prestonsburg to get care because there's no one there accepting or has availability to see them. We're overrunning the providers that are actually seeing patients, and it's gone from a specialty issue to a total plan issue. And guys, we can't just rearrange deck chairs. This is sinking, and we're the folks on the front line that will tell you that it's sinking. So thank you for looking at it. Let's keep looking at it, and let's get a plan to get out of this mess. But this network is not nearly as strong as what we're being told and what's being shown.
And I know from my standpoint, even though I'm a generalist, I have a little bit of, I guess you would say, I'm one of the, luckily in Somerset area, we have about 2 of us that do it, but take intellectually disabled patients. And I will tell you, the other one is getting close to retirement, which means I'm about the only one that really sees a large quantity of intellectually disabled in our area. And Peto's graduating them to me faster and faster, and we are hitting a limit on that for other reasons that aren't necessarily probably in this, with surgery center accesses, and which is a whole different topic. But network adequacy, if you have a few of us doing it here, the only option is send it to UK, especially with intellectually disabled, autism, things like that. And UK is a 2 to 3 year wait. What does that do to this vulnerable population? So, like I said, I used to feel bad about saying 6 to 8 months. I know the pediatrics used to feel bad about saying 6 to 8 months. I'm sure some of the oral surgeons I've talked to are saying 6 to 8 months. But our only other backup is 2 years. So that's one group that I know a lot of people don't talk about, and it's an often group that nobody sees. So, is there any other? And my question, and this is just kind of a recommendation. I know you said it was once a year you guys were looking at a claim. I would suggest a lot more than once a year because you have people who, a lot of people might see somebody once a year, and that's truly not seeing patients. So I would suggest a lot tighter.
I will, so that is actually a regulatory
Okay.
standard that's set. It's a, and so that's why it's 365 days. That's according to the regulation. You have to look at that. For
How does
fee for service, there's actually, they can be an automatic termination, I believe, for fee for service if if the claim doesn't come through the system, I believe. And I think it's 2 years, maybe 2 years for fee for service.
on how do I want to word it? And I know we've talked about before network adequacy, and I think somebody had mentioned it. Is it 2 days in an office counts as a provider location? Because one thing you do run into is providers listed within an office that might be coverage or they have a satellite practice. So when you're judging that, say, like my practice, we have 2 offices. Yes, I'm at each office maybe a day or 2 a week, but yet that's only one of us in that office a day or 2 a week. So is there a stipulation of, I guess you would say, for satellite practices when you guys are looking at this? Does that make sense, question-wise?
Yes, this is Chelsea again. Yeah, that makes sense. I would have to check with Rachel on that because I'm not sure if it's like a specific hour. You have to work so many hours in that office for it to be considered like full time. So let me check with our quality team, and I can write that as a follow up when I send the other information.
Okay, because
That's
that's
what I,
oh, go
sorry.
ahead.
If we were able to see that, what is asked, that would answer those questions. If we could access that, I mean, I know I can file an open records request, which seems extensive. If you could just, just see what you're asking the MCOs to provide, that would maybe we could provide some input on where we feel that we could better assess network adequacy. That's what I was getting at with the objective information and the corrective actions. Like what are they sending you? And I'm sure there's a specific questionnaire or something you're asking. If we could see that, or we can file a records request that if we need to do that, that's fine.
Yeah, oh, I think maybe there was a miscommunication. So I can send the information, from the corrective action plan. What I meant as far as open record is I wouldn't be able to send you a copy of that corrective action plan, like the formal, but I can extrapolate, the questions and the data from that, and send that to you. That's what I meant with the open records.
Sure.
Anytime, there's like a formal request for a document, it just has to go through that open records process. But yes, I can just pull that out for you all.
And then on the front end of that, like what obviously we would get what the corrective action plan was, but what DMS sends to the MCOs, like what information you're asking, I guess, is that something that you could provide us? Like, hey, you are sending your network adequacy report based on this information we want from you to assess that data.
Yeah, we can certainly and put that information in that request as well.
Perfect.
All right. And if there's no other topics on network adequacy right now, moving on to other.
I have 2 other. I have a quick one, and then I'd like to go on to a second one on credentialing. But the first quick one is a question for Justin and Derringer, and if Justin Colossi can help me out on the code for ligation. It's been brought to my attention, I was not aware of it, that the code for ligation after an exposure of an impacted tooth is not on the new fee schedule. And I know some of our MCOs are still covering those ligations, but some are not. And I just wanted to see, one, if that is correct, if that's not on the new fee schedule, and again, Justin, if you can give us that code. But two, if it's not, if we can understand why it's not, and what we need to do to get it back on there. Speaking to a provider, to an orthodontic provider this week, their comment to me is that's as if we're having someone gives you a boat and a truck, but no trailer to attach the two. And that's the truth of the matter. I mean, we're one of the criteria, one that we have very few of them, but one of the criteria for orthodontic approval is an impacted tooth. Well, we don't just treat those cases to open up space and hope they come in. Most of those cases, well, I would say most of those cases by standard of care do require exposure and ligation. The ligation, for those not in the know, is usually a gold chain which is attached to the impacted tooth, which is in bone. And then as orthodontists, we use that to bring that tooth down into the arch. If that code is not on there, I'm not sure that we're going to be very effective bringing in the majority of these cases in, looking specifically at canines. We can open space, we can open a hole, but the oral surgeon can open a hole, do the exposure. And our hopes can be that an open exposure will allow it to erupt. But without the ligation, without the tool to bring that down in, I don't think we have a great success with that. Colossa, can you give me that code? I'm sorry.
Yeah, it's D7283, and it's often coupled with D7280. Uh, I will say that the MCOs have been covering it after we reviewed it, but I did get input that it was not on the fee schedule, so it would be an EPSDT thing. So, but to me, it makes sense that that would definitely need to be on the fee schedule because we literally call it expose and bond. I also think it's actually in the Kentucky administrative regulations, specifically exposure and ligation for ortho. I'm not 100% sure on that, but I was just surprised. It's never been an issue for me. But then it was brought to my attention that a Medicaid provider tried to charge a Medicaid patient because it was a non-covered service an exorbitant amount of money, which was totally crappy on their part, no question. But I guess it's to prevent that from happening, to get it back on there. It seems like it should. I was shocked that it wasn't on there.
Babbage, I apologize. I don't know to say Mr., Miss, Doctor.
It's Doctor. I'm sorry. I'm Dr. Babbage. I'm pretty quiet most of the time. I'm the dental director for Passport Molina, state of Kentucky. So we just had this case, but the case came through the oral surgeon, and because the oral surgeon wasn't, is that what you're talking about? The oral surgeon had the problem, not the orthodontist, or
well, the oral surgeon tried to charge the patient an exorbitant fee.
Right. Well, that was covered. It was covered.
Okay.
The problem with the oral surgeon was what we require the oral surgeon to have is an orthodontic pre-op.
Sure.
So,
no, totally. Yeah. And I think
yeah.
they should be in braces. They should have a referral. We can make it as detailed and strenuous as possible because I don't do those unless Joe's sending me the case or another orthodontist. I don't do that free will.
So,
I mean,
that is definitely a covered benefit, and that was the only stipulation that the office manager. We had a one-on-one with an office manager at the oral surgeon's office, and we got that fixed pretty quickly.
Sure. And I don't think it was an MCO issue. I think you guys, if it's not on the state fee schedule, I wasn't even coming. My point was it needs to be on the state fee schedule so that you guys, the MCOs, have that to go off of. I wasn't criticizing any MCO in this situation.
No, I know. I just want everybody to know that's covered. Go ahead and as the TAC, if that's not on there, then we want you to take care of that, or help us take care of that, getting it on the schedule. That's something we use quite often. My granddaughter
Yeah.
had to use it, as a matter of fact. So, we use that. Thank you. And I'm sorry
Thank
you don't
you.
know who I am. You need to know.
I will look. I
Now,
will look
now you
into
know.
that. Yeah, let me see why that's not on there, and
Okay.
I'll look into it.
Thank you.
All right. Would that need to be followed up with in the meantime, just, or do you want to wait till next meeting on
No,
that?
it's. I mean, our fee schedule process is tight, so this is something that I'm going to look into. I mean, I'll let you all know something. Well, you know.
I had emailed Danny too, Justin.
Okay.
Actually, before he brought that up about this code, once I
I'll look
learned
at
her
it. I'll
email.
look at it this weekend, so
Cool.
it'll be quick. Just depending on what I find. If I find something that, oh, we cover it this way instead or something. I mean, I don't know, but let me just look into it. If it's something that we do need to add, then I will make sure that it gets into I think we've already sent that decision memo, but I'll make sure that gets in that and we update that because that's something important we need to make sure that we're looking at. So.
Since we're in February of 2026, and you said that fee schedule is still kind of pending at this point,
Mhm.
what is the timeline you think that we'll be seeing that? Any ideas?
Nope. I just that's been be honest. It used to be we used to have very specific time frames, and that's opened up a little bit last year. So, our goal is always that by the end of March it is done. It is posted. It's done. That is our goal. I can't promise it, but that's we're gonna do. Try to move heaven and earth to make that happen.
And since that's the 2026 fee schedule, will there be, I guess that's the thing, will there be a retroactive payment on those?
Well, so it will retro back to January 1st of 2026. Each MCO kind of handles that differently. For fee for service, everything that you've billed will automatically go through. So you don't have to do anything. Our providers don't have to do anything. That's an automatic process in our system. And then I can let each of the MCOs talk about how they do that in their system because it's not just for dental, it's for every provider type. So everybody kind of deals with that. And I wish it was better way to do it, but sometimes CMS doesn't even send us our stuff until like the end of January. So that's the frustrating part is that they're supposed to send it in like October or November. But with all the federal chaos, I guess, going on up there, that the last couple of years has been very late. But I'll let the MCOs talk if they want to about their process. That's for fee for service.
Okay, thank you so much. Any of the MCOs?
I can speak to UHCs if you'd like. We will. We're honoring the fee schedule that's in existence now, the 2025 fee schedule. When we get the updates for the 2026 fee schedule, if there's something that's been billed or an amount that has changed, we will retroactively update that automatically. We'll reprocess those. If the code changes, we will still honor the 2025 if you build it, but if you want to go back and do a corrected claim and bill the new code, that's up to you, up to the provider, and at that point we'll reprocess the claim.
Thank you very much, Dr. Ritt.
So that, and I say that because of the D9248, which is the moderate sedation code that's because we don't know what's going to replace that yet or how the state's going to handle that. So we're still paying the D9248 until there's a replacement code. And then it'll be the provider's choice, for example, to either build a new code or just stick with what they have up to that time.
Just going through my notes to make sure I'm still kind of keeping in line. Is there any other business? I know, Dr. Petrie, you said you had two. Did both that encompass both?
Well, the second one that under new business would would be looking at credentialing, and looking at, we keep talking about network adequacy, and one of the goals that we have had is to improve that. But we also have an issue with patients not being able to, or sorry, providers having issue with credentialing themselves, new providers, but also issues with it being unclear to providers what their credentialing requirements are. I think we've discussed this as a TAC, and I think it might be worthwhile for us to read in our recommendation, looking at credentialing that I believe we should put towards the MAC, but just in essence looking at what the credentialing process is, as far as trying to streamline for providers what they need to do on what timeline, and from that perspective, ideally we would love to see a single credentialing. Frankly, if we're credentialed with the state, I would love to see a scenario to where that carries credentialing with each of the MCOs, and it's not having to be so many additional credentialings. I mean, if you look at with each MCO and each of the different groups, I mean, we're up to 9 different people that you may have to credential with if you're going to be treating patients from all types of providers, so all of the network. So we think we'd like more clarity on that, and frankly, for that to be posted online or shown in a way that all providers understand it easily. Somebody jump in and help me with that. I've got a kid in the back.
Well, I'm going through that too, and that's kind of one of the questions elaborating I have on that is with dental, that's different than some of the other, of course, medical side. You credential with Aetna, you're credentialed with Aetna, you deal with Aetna, that's it. Or you deal with WellCare, and that's it. With dental, you're contracting a sub and a parent organization. So as those changes, which goes back to changes and giving time, who are you really credentialed with? I think that's even a question to ask, and who really holds that credentialing, because if you credential with WellCare, you can't do anything until you also credential with Avisus. If you're credentialed with Aetna, you can't do anything until you're credentialed with SkyGen. So why are we having to credential 9 different organizations?
Can they not use the CAC, the CAQH? Could this not be like a central single source credentialing process that would like push out or something? And you can just say, yes, I want to be a provider for X, Y, or Z. Is that something that we could try to get toward? That would make this a lot easier to get people to sign up.
Hi, this is Barbara from DMS. Is Chelsea still on here? That may be able to clear that question up.
Hey,
Chelsea?
Barbara, sorry,
Yeah.
this is Chelsea. I was just trying to kind of digest the request because it's tricky. You know, our current contract indicates that the MCOs, you know, have to contract individually with providers to be in network. And so you know, when they have a subcontractor, ultimately that MCO is responsible for their subcontractor and for oversight of that subcontractor. And then if, you know, their subcontractor is providing any type of claims payment or claims review for, you know, example for dental, like SkyGen or Avisus, you know, because that is part of the MCO's requirements for obtaining a subcontractor. You know, I don't know if there is a way to streamline that, to be honest, to one application. Because you have to think of it in terms of it's credentialing, but it's a contract. You know, you are signing a direct contract with that MCO and with that MCO's affiliate. And so because each contract is set with its own negotiated rates, its own payment methodologies, things like that. I mean, it's really hard to streamline a single application when multiple entities are involved. And Justin, I don't know if you had any insight into that either, but I just feel like it's tricky with how our contract with the MCOs is set up.
It is tricky, but it's something that we can look at. I mean, I think that's, anytime everything we do, we want to improve, right? And so, and one of the things that we want to do is to make it easier, administratively, is ease administrative burden. I mean, that's something that we've been trying to focus on for the last 2 or 3 years for all of our, providers. So it's definitely something to think about. I would love to be able to look at that. If that's something that you all wanted to put in front of the MAC, that would be a great one. It would be something that we would have to include in our new MCO contracts. It would need to be something that I think there are ways to do it. We may want to use, get maybe Commissioner Lee to look at what if other states have implemented that use managed co-organizations. Maybe even if we could just have like something as simple as having a central area, like DMS when you first sign up with DMS to kind of cover everything basic and have all the MCOs share all that information, just like licensures and those type things. Of course, you would still have to sign a contract with each individual managed care organization. But I mean, there are definitely ways to improve it and make it easier, and I think we're all for that. So I don't think there's a short-term solution for it because again, that would need to be something that we included in our contract with the MCOs when that comes up for renewal. But I think it's great to start that conversation, and it may be something that we have maybe like a little subgroup that meet and go over different topics, and we include some different provider types too, so that we can kind of, make improvements overall. I think that's a great idea.
And just, I don't know if you're familiar with CAQH from the dental side, that most dental use. Um, have you heard of that?
I have not real familiar, but I've heard of it. Yes.
But I mean, it's basically kind of like you said. I mean, it's the credential. You put your license, you put your insurance, you put everything in there that you want. And as far as from a credentialing standpoint, all we have to do is say, "Yeah, I'm going to give this person access." They can access all your data. Um, so it's really more just signing I guess, as you would say, possibly an individual contract. The credentialing is done. Um,
Robert, I can say that Visas does recognize CAQH. We recommend all doctors to put their information in there and keep it up to date, so that if they're credentialing or re-credentialing, all that's already there, their licenses, their DEA, everything they need is pretty much there. Plus, there may be another form or two that goes with that to complete the process, but we absolutely do accept it.
okay. Thank you, Dr. Cottle.
BJ, I just to follow what you said, and I think certainly, ideally, and long term, our goal is and would be that we look at a single entity or a streamlined credentialing process. In the short term, though, as providers are contacting us and saying that they have fallen off with credentialing or they don't understand their credentialing because they don't understand the timeframes because there are so many different groups to credential with. If we could have, not in essence, a clearinghouse, which CQHC would allow for, and that I think is the long term, but in the short term, have even somewhere posted that what the credentialing timeline is and how long individuals are credentialed, so that they can have a better understanding of what is due, when is due, and things like that, much like we do with our licensure board.
And I agree with Dr. Petrie on that because I know, luckily I had good luck with, and to give Avisus some credit on this, I somehow got out of realm with Avisus and got out of credentialing, never gotten a letter, don't know if it got lost in the mail, what happened, and was able to get my re-credentialing done, and they retroactive everything for me on that. But once again, that was a major headache, administrative burden, because somehow I didn't get my recredentialing. And as Dr. Petrie said, if that was on a form, we could easily, a website, something that would easily help remedy that.
And I
Any other?
just wanted to clarify about the credentialing timeframes. Are you referencing like fee for service credentialing, MCO, or all? I just want to make sure.
All. Really all, including
Okay.
fee for service. I know I did have some issue with the fee for service, and it took a while, but I will give, because it was through the new online gateway platform, and it was right when it was getting set up, and it was a disaster. But I give the state people I worked with credit because they really were great and helped get through that process well. It was right when it first started, so there were a lot of hiccups. But I haven't had to do it since then. But I know my partners have, and it seemed to work a little bit better. So for them.
Okay, great. I just wanted to make sure I captured
But
all
yeah,
of that.
I think a lot of people need to probably know where that is. So having that listed too in the process and the time frames would be very helpful because it isn't the easiest to find.
Absolutely. Okay. Thank you for clarifying.
So, anything else to go on right now in new business? If not, is there any recommendations that we need to look for to go to the MAC? And I know we had made a recommendation last time, and I apologize for my ignorance in the process of getting things through everything as still learning. So I did not get that submitted for MAC. So I don't know if that's something we need to table to revisit that recommendation, or how we want to proceed with that.
So
As a
the so this is Barbara from DMS. I'm sorry to interrupt you,
yeah,
but I'm supposed to receive it in writing.
yeah,
I know that Danny is now going through a new process through Google. And Danny can probably speak more to that at the next meeting, but all recommendations need to come through me, email, which is fine, but I can't write those for you. You have to submit them to me.
correct.
Barbara, thank you for that. We actually have some recommendations that that we, in the interest of the time, I think we can read in, including the one that got tabled. And don't be so hard on yourself, BJ. We also had a change in who our MAC representative was, unfortunately. So that also affected that not going forward. But I think in the interest of time, most of our recommendations have been discussed, just not formally written, put into record. So I think if someone could read in the recommendations that we have, and then we can vote on those on camera, and then we can send those on in a written format, then we can move forward with those.
Yes.
Does anybody want to? Of course, recommendation number one was involving the one that was last time. Are we still wanting to carry that recommendation from last time forward? I believe so.
Yes.
So recommendation number one would be the TAC be involved with fee review as it relates to DMS and dental services. Is there any motions or discussion regarding that recommendation?
I'll motion.
Second.
I'll second it. Yeah.
And call for a vote of members.
Aye.
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 Seeing none, that recommendation to go forward to the MAC. We have recommendation number two that we'd like to post from the Dental TAC Committee. To have public posting of dental credentialing processes and timelines for dental providers and other providers as it relates to their specialty. Format should be easily viewable and able to locate, and should address the following: contracted dental benefit administrators and direct contact of state dental director, regional directors, if applicable, and provider relation team members, dental credentialing and recredentialing requirements, and credentialing timeframes and effective dates. Any discussion?
Motion to approve, Petrie.
Do we have a second?
I can second.
Second, Dr. Tell. Move to vote.
Aye.
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 Caitlin, I didn't know if. Okay. For some reason, your audio is not on for some reason.
Sorry. Aye.
So, any opposed? Seeing none, we passed motion to send to MAC. Recommendation number 3, evaluation of a single source dental credentialing model. Any discussion? Seeing none, is there a motion to accept this recommendation to go to the MAC?
Motion.
Dr. Colosum moves. Any second?
Second.
Second.
Move to vote for recommendation number 3.
Aye.
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 Any opposed? Seeing none opposed, that motion will be recommended to the MAC. And I think, was that the only 3 we were wanting to do? I know there was a couple of others potential, but
I'm comfortable with those.
okay. So we'll make those 3 recommendations. I will get them written up. And Ms. Walsh, do I need to send those to you?
You can send those to Danny, and her email address is in the chat, and you can carbon copy me so I can help her with the follow-up.
All right, perfect.
Mm-hmm. Thank you.
All right, thank you so much.
Mm-hmm.
And is there any other discussion that needs to be addressed at this time? Is there any comments that need to be addressed to the TAC from anybody on the phone call that the chair needs to recognize? Seeing none, do we have a motion for adjournment?
Motion.
Motion made by Dr. Kloss for adjournment. Do we have a second? Second, Dr. Petrie. Thank you all for your time, and I will work on getting some things to you, Danny and Ms. Walsh, and I appreciate everybody being on the call.
Thank you all.
Thank you.
Thank you,
Have a
PJ.
great weekend.
Thank you very much.